If you had 3 patients in front of you, let's say wet AMD, retinal vein occlusion, and diabetic macular edema, could you describe the OCTs that you might see in these patients? Could you draw those OCTs? Well, I think that these skills are very important, both in terms of diagnosis and treatment. My name is David, and I'm here today from EyeCare PD, where the PD stands for Professional Development, and we're always learning. So let's get started. This is something that I always like to show people. It really questions how you understand and learn things. How do you know which one's the apple? I mean, it's pretty easy for you to pick out, right? You know which one's the apple. But think about it. These are two-dimensional images in grayscale, and yet you can pick out an apple almost instantly. It sort of makes me wonder, though, why would anyone ever think that this OCT image is wet age-related macular degeneration? Well, there's probably several reasons why people might actually think that, but we're going to go through some findings today that I hope will help you be able to prevent this as a stumbling block and catapult you to some new skills. In order to understand actually how you can really become a master at interpreting OCT and how you can use OCT to both better diagnose and better manage, better treat patients, I think it's important to actually go all the way back to the basics. If you look at the very basics, which you can see on the left is just a simple cartoon image, and on the right is the OCT. And what it shows you is that the OCT is really looking at the neural architecture. It's really this view in vivo of the retina, the nerves, and the health of those nerves and of the eye in and of itself. And once you understand that, I think you go quite a long way. Of course, the OCT can be broken down into its anatomical components. You've got all sorts of layers which are labeled here in this image. And really, this is the anatomy. I mean, think about it. We used to only look at this under a microscope. But now we're looking at it in vivo all the time. But I think perhaps it's even simpler to look at an OCT. You really don't need to know all of those layers and all of those different descriptions of how different diseases can affect each individual layer. Rather, it's much more simple to just break it down into the fact that varying diseases affect varying retinal layers from a basic pathophysiologic point of view. Take this example. This is the area affected by retinal vascular disease. It's basically the inner retina. This is the area affected by choroidal vascular disease. Again, we're talking outer retina and choroid. If you can understand this, if you can understand why, then you will understand OCT interpretation. And I'm going to spend the next few minutes helping you to understand the importance of this distinction, because it's not about just finding all the different layers and knowing which layer is swollen when, but rather there are certain patterns that you can use to determine very quickly what's the diagnosis and what's the best treatment. What do I mean? Well, let's look at these 6 examples. In these 6 examples, you see that they all look very different. You might not, at a very quick first glance, have the words to be able to describe each of these 6 images, but yet all of these images look very, very different. Let me help you out here by giving you the words to begin to describe these images. Here are the words that we often use. You can see on the top this OCT that I've labeled as compact. Compact really just meaning that the neural tissue is all squished together. It's all appearing in a normal anatomic variant. As opposed to this one with intraretinal fluid. The intraretinal fluid actually has a speckled appearance. The one down below, intraretinal fluid, has a diffuse outer thickening appearance. Look, the fluid's confined more to this outer aspect of the retina. Intraretinal fluid with empty cysts, that's different than what we saw earlier in the speckled configuration. In this image, we've got subretinal hyperreflective material here and here, along with subretinal fluid. And in our last example at the bottom, we've got subretinal fluid, a pigment epithelial detachment, subretinal hyperreflective material, and intraretinal fluid. All of these descriptions will in turn lead you to be able to come up with a diagnosis. In fact, if you look at these 6 images, they're fairly typical for these diseases. Boom, there you go. You've got normal, diabetic macular edema, a retinal vein occlusion, post-op cystoid macular edema, inflammatory choroidal neovascularization, as denoted by the fact that there's 2 foci of choroidal neovascular tissue, and finally, on the bottom, wet age-related macular degeneration. Now, when I look at these OCT images, I actually don't even just see the description or the diagnosis. I'm already looking at them and seeing prognostically how these patients are going to fare and what we might need to do to treat them. But hang on a tick, because before you can get to the prognosis, you need to be at the diagnosis. And before you can get to the diagnosis, you really must be able to describe the images accurately. So again, showing you these descriptions of these images, these are common OCT words that we use to be able to describe the OCT. And really, it's that description of the patterns that's going to lead you to the right diagnosis. And of course, that in turn will lead you to all the next steps, such as treatment. If we go back to our image of anatomy, many people talk about complex descriptions of OCT appearances. They'll talk about the fact that maybe the nerve fiber layer is swollen or the inner plexiform layer is affected. But you can see just from my previous slide that the descriptions that are actually much more effectively used in the literature don't describe simple individual layers, but actually look at much broader patterns and use those patterns to actually determine the diagnosis. In fact, looking at an OCT, there's probably 2 critical layers for most interpretation skills, and those are the ellipsoid zone and the RPE, or Brooks membrane complex. And if you can effectively use those 2, or find those 2 aspects of the OCT, then you're going to go a long way in being able to interpret it. Online, I have posted on my website, EyeCare PD, a macular OCT glossary. And these are some of the terms that you'll find there. What I'd like to do for a few moments is concentrate with you on a couple of the very basic terms, such as subretinal fluid and pigment epithelial detachment, because these 2 terms are going to really be paramount important for a lot of the outer retinal pathology, specifically choroidal vascular disease. So let's take a look. Let's start with subretinal fluid and talk about this pattern, how you would find it, and what you would see. Here is an OCT image, and what you can see is that there's a hyperreflective space indicated by the star that's consistent with subretinal fluid. How do you find that subretinal fluid? Well, it's simple. You start by identifying the RPE, the retinal pigment epithelium. Then you find the ellipsoid zone. Anything that's hyporeflective between the ellipsoid zone and the RPE is subretinal fluid. And that's Pretty straightforward. Pigment epithelial detachments. Let's take a look. Pigment epithelial detachments can be seen in this image, or rather there's one isolated large pigment epithelial detachment that's seen in this image, again simply found by identifying the retinal pigment epithelium and looking for areas of elevation. Those areas of elevation of the RPE are going to be your pigment epithelial detachment. This ability to discern subretinal fluid or a pigment epithelial detachment is going to be very important. I mean, just think about that for a moment. If somebody has isolated pigment epithelial detachments without subretinal fluid in a case of age-related macular degeneration, they've got dry AMD, as opposed to the addition of subretinal fluid would make you very suspicious for wet disease. But I digress. Let's go back to our simple example here. Here, we've got a patient with what? Well, you've got the subretinal fluid indicated by the stars. You find that by identifying the retinal pigment epithelium and the ellipsoid zone and looking for a hyperreflective space between. You can see as well that there's also a pigment epithelial detachment. So this patient has both a pigment epithelial detachment and subretinal fluid. What about this case? Well, let's go through our steps and find our landmarks. There is the RPE. There is the ellipsoid zone. That space between them is subretinal fluid. It's a small amount of subretinal fluid, yes, but there's subretinal fluid nonetheless. And, of course, you can see quite obviously that there's a pigment epithelial detachment. So I've given you the tools to take the first step in terms of this image interpretation. So now, let's play. Take a look at the image. Think to yourself, is this subretinal fluid or a pigment epithelial detachment? What do you see? Yes, you've got subretinal fluid, a hyperreflective space between the RPE and the ellipsoid zone. That space is subretinal fluid. So this is a patient with SRF, subretinal fluid. We use the abbreviations because it makes charting much easier. The jargon is quite useful in discussions as well. SRF. What about this patient? Do they have SRF or a PED, subretinal fluid or a pigment epithelial detachment? I can't tell you how often I get referrals for patients just like this. And somebody will write pigment epithelial detachment, but I'm sure you know by now, just from my initial explanation, that this is a patient with subretinal fluid. Here's the subretinal fluid. Here's the subretinal fluid. Find the RPE, find the ellipsoid zone. The area between that's hyperreflective represents subretinal fluid. Wow, we're well on our way. Let's take a look here at one more example. Subretinal fluid or a PED? Well, this is pretty straightforward. Here's your RPE. Here's your ellipsoid zone. The area between, hyperreflective space, subretinal fluid. You've got a pocket there. You've got a pocket over here. Now, you might say here that this is a very shallow pigment epithelial detachment. And I would tend to agree. It's a very low-lying pigment epithelial detachment. So this patient would perhaps best be described as having both SRF and a PED. Now there's a lot of terms, there's a lot of descriptive words that are out there that we use to describe OCTs. And they're all very important because if you think about it, every OCT has a story to tell. And knowing these terms will help you tell that story. What do I mean? Let's take a look. Here's an example of an OCT. The question at hand is this the right eye or the left eye? I've not talked about it yet, but with your knowledge of anatomy, I bet you can figure it out. Yes, this is the left eye. How do we know? Look at the nerve fiber layer. The nerve fiber layer is thicker on this side, which means that the optic nerve is going to be located over here, as opposed to this side where the nerve fiber layer is thinner. So this is an example of a left eye. Kind of fun, huh? All right, let's try something a little harder. Here we've got ellipsoid band loss. Why? Why is there ellipsoid band loss? Well, let's look. Let's follow the ellipsoid zone right across, all the way across, and boom, it's gone. We don't pick it up until it comes up on the other side. This area of ellipsoid zone loss is consistent with atrophy. Atrophy in an elderly patient would be most commonly associated with dry age-related macular degeneration, but nevertheless, this is an area of atrophy. And look here. What are these circular structures? These circular structures with a hyperreflective center with a very bright rim. That's not intraretinal fluid. Those are outer retinal tubulations. Outer retinal tubulations are going to be another sign of chronicity of disease. In this case, chronicity associated with atrophy. Okay, this is the image that we opened up our whole talk with today when I said, is this AMD or CSR? Why would anybody ever think this is CSR? Well, you might think it's CSR if you're not quite clear on how to interpret the OCT. What do we got? We've got pigment epithelial detachments, but this pigment epithelial detachment in particular has this hyperreflective speckling compared to this hyporeflective area beneath the other pigment epithelial detachment. What's my point? This is a drusenoid pigment epithelial detachment. Drusenoid. Over here, you've got more evidence of drusen. So you've got drusenoid pigment epithelial detachment, probable serous pigment epithelial detachment, and drusen. This is definitively age-related macular degeneration and not a case of central serous retinopathy. Remember, pigment epithelial detachments come in three main varieties: drusenoid, serous, and vascularized. Drusenoid would be, as you see here, with this hyperreflectivity below it, relatively homogeneous in nature. Serous is not going to have much speckling inside of it. It's going to be basically hyperreflective. And a vascularized pigment epithelial detachment will often have these striae, which is not seen in this image, but these striae of reflection below the PED. So again, this is a case of AMD. What do you think of this one? What's the diagnosis here? Well, let me ask the question in a different way. What's the refractive error of this patient? Yeah, you can take a guess from the OCT. Did you get it yet? Can you see the way that the RPE, the choroid, the whole eye curves? Yes, that's a staphyloma. And look at the choroid here. This is the choroid. This very thin hyporeflective space below the RPE just before the choroid, just before the sclera itself. That is a very, very thin choroid. And what else do you see? One final clue, an epiretinal membrane. Well, think about that. An epiretinal membrane with a staphyloma and a thin choroid. Those are all signs of myopia. So this is a patient with myopia. What if I were to show you this one and ask the same question? What's the diagnosis? Yeah, I get it. A lot of you are going to jump and go, yeah. David, it's a myopic patient. Yeah, it's true. There's a staphyloma and there's a thin choroid. But what else do you see? Your eye is drawn to this area. Do you know the words to describe this area? Well, that's what we're going to review now. That area is best described as subretinal hyperreflective material. Subretinal hyperreflective material is part and parcel with the diagnosis of choroidal neovascularization. So this is a patient with myopic CNV. And we can make all of that diagnosis simply based on the OCT. So again, if we take a look at our giant glossary of terms that we can use, we're going to focus for just a few minutes on subretinal hyperreflective material. Both of these images demonstrate areas of subretinal hyperreflective material. In the top image, the circled aspect is subretinal hyperreflective material. This is a type of subretinal hyperreflective material that we'll often refer to as amorphous. Amorphous means that the pixels have some spread between them. They're diffused. It's not clear where they start and where they end. As opposed to this area that is also subretinal hyperreflective material has a very different appearance in terms of the pixel density. The pixels are much brighter and squished together. You can very clearly delineate the borders. This difference is very important because this determines relative activity. Let me explain. In this area above, where we've got amorphous subretinal hyperreflective material, we have an area of active choroidal neovascularization. This is a patient that will need to be actively treated with anti-VEGF, vascular endothelial growth factor, anti-VEGF medications to treat their active choroidal neovascularization as diagnosed on OCT by the presence of amorphous subretinal hyperreflective material. Compare that to the patient on the bottom. This patient has consolidated subretinal hyperreflective material. That would indicate that the choroidal neovascular tissue is inactive. They perhaps were treated with a series of anti-VEGF injections that resulted in resolution of the CNV and no longer substantive activity. You can see that, again, just by the OCT by looking at the pixel density. Can you see the difference? Now, I get it. This difference is subtle. And in fact, if you really think about it, if you think about choroidal neovascular activity in terms of its overall activity in a patient that's being treated with anti-VEGF injections, you can see here that we've got amorphous subretinal hyperreflective material to begin. These hyperreflective pixels that are relatively spread out, indistinct, hard to know where they start and end. And then as injections are given to a patient, you can see the subretinal hyperreflective material in the process of consolidation. Meaning, the answer is not always A or B. It's a spectrum when it comes down to subretinal hyperreflective material. And I'm not asking you to simply leave this lecture being able to readily distinguish amorphous from consolidated subretinal hyperreflective material. Although, if you ask me, I do have a few tips for you, and I will show you a few more slides to help out. But no, my point is much simpler. Being able to identify subretinal hyperreflective material is important because it's a key finding in cases of choroidal neovascularization. And understanding that the subretinal hyperreflective material can look different as the choroidal neovascular disease progresses, either naturally or in response to treatment. Understanding those differences is going to be very important in terms of you being able to better manage your patient. There you are, the area of consolidating subretinal hyperreflective material. For those of you saying, boy, David, that's really subtle, let me show you a few cherry-picked examples to help build up your confidence in understanding and being able to readily locate subretinal hyperreflective material. So, step 1, find the subretinal hyperreflective material. Step 2, tell me if it's amorphous or consolidated. I'm going to give you a hint. On each of the next few slides, there's only one image that's amorphous and one image that's consolidated. Did you find it yet? There is your subretinal hyperreflective material, and this is going to be the amorphous variant on this slide set. Here is your consolidated subretinal hyperreflective material. Let's look at another. Did you find it yet? Do you know which one's which? Good. There is your area of subretinal hyperreflective material. That's active choroidal neovascularization in this patient. Here is your area of consolidated subretinal hyperreflective material. It's far too deep into the retina to be drusen. Perhaps this is drusen, but this area is an area of consolidated subretinal hyperreflective material. Let's look at another. Find the area of subretinal hyperreflective material. Which one's which? Let me start at the bottom. There's your subretinal hyperreflective material. It's amorphous in nature. On top, here you've got your consolidated subretinal hyperreflective material. What else do you see? Yes, outer retinal tubulation. 1, 2, 3. What did I miss? 1, 4, 5, 6, 7. Yes, those are areas of outer retinal tubulation that are going to be consistent with chronicity. That chronicity would go part and parcel with a consolidated area of subretinal hyperreflective material in a patient with chronic CNV that perhaps has been treated for years with anti-VEGF injections. There's a lot of power to being able to interpret these OCTs. They tell you the whole story of the patient. How about this image? Did you find the subretinal hyperreflective material yet? Here it is on top, consolidated subretinal hyperreflective material. And on the bottom, again, amorphous subretinal hyperreflective material. And what do you think of this patient? Look at that staphyloma. Wow, super thin choroid. That is another example for you of myopic choroidal neovascularization with the presence of amorphous subretinal hyperreflective material as an early sign of CNV. In fact, in myopes, it's one of the earliest things that you're going to see is subretinal hyperreflective material without very much intraretinal fluid or subretinal fluid. That would not be the same, for example, in wet AMD. In wet AMD, when you see the subretinal hyperreflective material, you're often going to see other signs, such as subretinal fluid and intraretinal fluid, and perhaps even a pigment epithelial detachment. But in myopes, you need to watch out for that very subtle subretinal hyperreflective material as a very early sign of choroidal neovascularization. Okay, so we've got this big list, and I think the obvious question becomes, well, do you really need to know it all? Well, you of course know my bias is already going to be yes. You really do need to know all of these terms. But let me hammer home one more time as to why that's so important to know all of these terms. Here, we've got our 6-up example of the different types of pathologies that you can run into. Let's take a look here. This example shows a patient with, yes, a little bit of subretinal fluid, but these cystic spaces of intraretinal fluid are relatively empty. And that pattern is very typical for cystoid macular edema that can commonly be seen in inflammatory etiologies, perhaps postoperative. This is going to be very important because this might be a patient that you elect to treat. You elect to treat them topically with topical NSAIDs. Yes, you need to be very careful to make sure you're not missing other pathology. But the point here is that just with the OCT and understanding the importance of the descriptive terms to lead you to the diagnosis, you might be able to treat. You want to make sure that they don't have subretinal hyperreflective material or other signs of other disease. But in this case, you've got a very clear-cut case of post-op CME. Maybe you're going to treat that with topical NSAIDs. Here, you've got an example of 2 different cases. On the left, a case of a retinal vein occlusion, and on the right, a case of wet AMD. if you're able to know that with diagnostic certainty by simply looking at the OCT, meaning on the left, the patient of the retinal vein occlusion, looking at the diffuse outer retinal thickening, and that spread of intraretinal fluid, and you know that on the right, you've got this patient with pigment epithelial detachment, subretinal hyperreflective material, subretinal fluid, and intraretinal fluid, you know that constellation of signs is indicative of wet AMD. Sure, both need to be referred. I get it. But the patient with wet AMD needs to be referred in a much more rapid manner. I have a whole talk that talks about the timing for referrals, why certain patients need to be referred faster than others. But patients with wet AMD, time is vision, because that CNV is going to scar, as opposed to the macular edema and a vein occlusion is not going to scar. You've got a lot of time. So if you have limited access to a retina specialist, you want to triage this so that the patient with wet AMD gets in faster than the patient with the vein occlusion, and thus using the OCT to triage your patients properly and help manage them better. Okay, so I hope that I've convinced you that knowing all of those terms, and we've only touched on a few of them, but going through them all and knowing them all is going to be very important to lead you to the right diagnosis, prognosis, and treatment. But really what we've been focusing on is looking at the OCTs qualitatively. But there's a whole different way to look at OCTs in terms of quantitative analysis. So let's take a few minutes and actually break the OCTs down to understand a little bit more about quantitative analysis of OCTs. Here, you have a standard report from a Zeiss Cirrus OCT device, and this standard report provides a lot of information, and I'd like to break it down for you into its components. Let's begin with the qualitative analysis that can be seen here in both the horizontal and vertical images, and you'll find those corresponding parts within the navigation lines that you can see overlying the map. Well, this area of qualitative analysis is often best viewed in grayscale, although you will occasionally see it in a colorimetric appearance for the qualitative analysis. Zeiss is one of the few companies that's really gotten their colors correct and provides a very good way to look at it with colors, but as we have learned with further research studies, the grayscale image is really finely tuned for the human eye, and this is now my preferred method for viewing the OCT, again looking at it in the grayscale for the qualitative analysis. Of course, there's a great deal more parts and more information on this sheet, and I'd like to go through a few of those with you. As we zoom into the topmost section, what you'll notice principally is that there's a lot of identifying data. Perhaps one area that gains a lot of attention is signal strength. That gains a lot of attention in the area of glaucoma scanning, where it's very important. However, in macular OCT scanning, that's not quite as important, and you can actually do a lot even with a lower signal strength. But again, you've got your identifying data up top. Again, you look at the sort of heart of the report, you can see that there's a lot of different sections, and we're going to start with this more top section, which has a few parts. One is this area here, which is the map. It is a topographic representation that measures the thickness of the retina as measured from the ILM, the internal limiting membrane, all the way to the RPE, the retinal pigment epithelium. And what the device does is calculate at thousands of points. Here, 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 here. It calculates at all these points to determine the thickness of the retina at varying places. It uses a colorimetric scale, which you can see here on the side, to indicate relative thickness, where these red or hot colors indicate areas where things are thick, and cool colors, these blues, indicate areas where things are thin. This is a very normal appearing map. Of course, on the other side of this image, you're going to notice something different. And what this is this is a statistical analysis of the retinal thickness. Yes, these are actually numbers that represent the mean for that particular quadrant. So that would be the average thickness within this quadrant. But you'll also notice this background color. This background color being green indicates that it's within normal limits. It's important to realize that this green in this statistical analysis has very little to do with the green here in the colorimetric analysis for the maps. I'm going to show you more what I mean in just a minute, but keep that in mind for just a moment. That green on the statistical map is different. As we move down to the more central part of the image, you're going to notice a few things. We've already talked about these qualitative analyses over here. You've also got three-dimensional images. These are things that a lot of my colleagues find quite useful to be able to look at ILM maps or RPE maps, or the total ILM to RPE map as indicated at the top. Again, just looking at it in a different display, a more three-dimensional display than the 2D view on top. But you can take a look at those if you want. Meanwhile, you've got here this very important colorimetric band, which is labeled as the diversified distribution of normals. This distribution of normals is a statistical analysis, and anybody whose retinal thickness falls within the range of a 5 to 95% standard bell curve is going to fall within normal limits. If you're a bit thicker than normal, you'll be a straw color, very, very thick, pink. As opposed to if you're down here, in that yellow color, you're going to be thin, and red would be very thin, very abnormal. You wouldn't expect to find that in more than 1% of the population, so it's quite a significant indicator for you. As you pull out, you can see, wow, that colorimetric pattern here for the statistical analysis is what's used to reflect down here in all these background colors, this 284 for the central subfield thickness, the cube volume, as well as the cube average thickness, and finally in this statistical area. To hit it home one more time that this background green is not directly related to this green color, let me show you some examples. Take a look at these two patients. In these patients, what you can see is when you're looking at the image qualitatively, that you'll see some areas of atrophy. When you look at the map, you're going to notice that there's more blue than you would expect centrally, along with these patchy areas of blue, which would indicate areas of retinal thinning. What you notice, however, when you look at the statistical map here, is that those areas that are statistically thin are labeled red. Again, the red indicating that it's statistically thin. That red is not from here. This is the colorimetric band that's used to determine the map. But this statistical representation, these background colors, are actually determined by this information down below. So again, to show you the adjacent example, when you look at the actual thickness map, you'll notice that this area is red or thicker than normal. But when you look at it in terms of a statistical analysis in this section here, you'll notice that those areas are now labeled pink or this very light straw color, which indicates, if you look down here at your distribution, that those areas are thicker than normal. They fall outside of that 95% range. So they're quite deviated from normal. Again, you're going to see a lot of information on your standard printout, and it's important to be able to understand which parts in terms of the colors correlate to which areas. Of course, there's one area on this that I didn't touch on, which is this macular cube, 512 by 128. What does that number really mean? Well, what it means is that if you look in the terms of the number of cuts from top to bottom in this plane running vertically, for all your horizontal cuts, there's 128 cuts horizontally. And what we're looking at in this image really is only one single cut. You need to recognize that there's more than one cut, and let me show you a very simplistic example as to why. Here's a patient that's a 65-year-old type 2 diabetic with a 1-month history of visual loss. Here's an image of their OCT. You can see that their map shows a little bit of thickening, and on the OCT you can see these cystoid spaces. And with just this information and just this single cut of the OCT, you would be hard-pressed to give a diagnosis of anything other than diabetic macular edema. However, I want to illustrate to you what happens when you end up scrolling through all of the cuts. Let's take a look. Did you see it? Right there. That is a full thickness macular hole. And what's interesting is that the initial cut that was displayed was not directly through the macular hole, and as a result, you didn't see it. All of this is to show you that one cut is not enough, and you really need to be able to scroll through all the images and look at them all to be able to find the true diagnosis. Let's tie all of this together as we wind down our time together in the concept of what I like to refer to in learning as a path map towards mastery. We're all along a path. I call that a path map. Our education, we're always learning, and we're moving towards mastery. But mastery is an asymptote. You can never reach full mastery. You can only inch your way closer and closer and closer. And I hope that this information is going to help you inch your way there. And to help prove what you've learned to yourself, let's take a couple more patient case examples. And why is all of this so important? As I write right here at the top, it's because expertise enhances your practice patterns. The more of an expert you become, the better your practice patterns will be. So this is going to be a question of, does this patient need drops, for example, NSAIDs, anti-inflammatories, or an injection, an anti-VEGF? Let's take a look. 60-year-old female, best-corrected vision, 20/50, borderline diabetic, 1 month post-uncomplicated cataract surgery. Fundus image, not particularly remarkable. Certainly you don't see any blood. On the OCT, you see this very classic pattern that we've shown a couple of times today of these cysts. They're relatively empty. Yeah, a little bit of speckling, but that's not the amount of speckling you'd normally see in quote-unquote speckled cysts. These are relatively empty. They've got this pattern of cysts straddling the fovea, a small little pocket of subretinal fluid. Let's take a look here at our map. Look at that map, that very large symmetric area of retinal thickening, and let's give you all the cuts. By the way, I'm going to tell you that the segmentation software was correct, so it's one less thing to think about. Look at those cysts straddling the fovea, sort of symmetric on all sides all around. What do you think this diagnosis is going to be? This is going to be a diagnosis of post-op cystoid macular edema. This is going to be a patient that's going to be best managed with topical treatment, such as NSAID drops, rather than anti-VEGF injections. You can tell all of that just by the OCT, the absence of subretinal hyperreflective material, the absence of drusen, the absence of PEDs. The very typical appearance of these empty cysts in this symmetric pattern around the fovea are all indicative of a post-op CME case. Again, same concept, expertise enhances practice patterns. Let's look at another case. This is a 60-year-old female, best corrected vision, 20/50, borderline diabetic, 1 month post-uncomplicated cataract surgery. Yep, exact same patient profile as you saw previously. But what do you see on this OCT? Well, a couple things. One, you've got this cyst. The cyst has a relatively empty pattern to it. It's relatively central as well. You've also got these hyperreflective foci. Hyperreflective foci can be many things, it's true, but often they're exudate. So we've got hyperreflective foci, this cyst. You're wondering, could this be a cyst like an empty cyst of post-op CME? But you know what, David? Here's hyperreflective foci, and there's even changes over here. Show me more. You got it. I will. Here's the map. Look at that map pattern. That map pattern is not that symmetric surrounding of the fovea. Here we go, scrolling through all the cuts, a lot of hyperreflective foci consistent with exudate. You do not see that symmetric pattern of empty cysts. In fact, there's variable cyst types. Some of them are speckled, some of them are more empty. Overall, when you look at that entire pattern, you're certainly thinking that this is a patient with diabetic macular edema. This is a patient that's going to do much better with anti-VEGF injections as opposed to any other treatment. Think about what you've been looking at overall. You've really been looking at an OCT in a cross-section. But of course, there's other ways that you can look at OCTs. You can also look at OCTs on Foss, or almost like this bird's eye view from above. If you take a look here at this sort of very quick example of the cases we've seen, you can see at the top you've got a normal patient. This is what a normal on-Foss OCT looks like within this slab region. And then on the left, you can see a patient with diabetic macular edema, on-Foss OCT. On the right, cystoid macular edema. This is a way that you could use your current existing technology, your OCT device that's in your office right now. You could look at the images on Foss, and you can see that instead of just looking at them in these qualitative cross-sectional images, or perhaps quantitative maps, which are not on this slide, instead of looking at them in that manner, you could look at them on Foss, as you see here and here, and that perhaps could provide an entirely different perspective and maybe assist with diagnostic accuracy. So looking at the technology in a different way is important. You've got this in your office right now. The other important aspect as to why I highlight this is because you need to, when you're looking on Foss, understand which on-Foss cut you're looking at. And the on-Foss cut in this case is between these segmentation lines, between the purple ones. That's what we call a slab. This is the slab you're looking at. Again, between the two purple lines, that's the slab you're looking at. This becomes very important as we start to think about OCT angiography, because OCT angiography uses an on-Foss view, and it very much matters which slab you're on. And what I would encourage you all to do is begin to think about this and use it, because as you're progressing along your path map, you need to understand where you're at, and you need to understand those slabs and the concepts associated with that. So what I tried to do is to give you a little teaser of some things to come, some other things that I talk about, some other things that Zeiss talks about. I know that we're all at different spots on our path map, but I think all of us are moving towards this concept of mastery. Remember, mastery is an asymptote. You're never going to get there. You can only just keep improving your expertise and getting better and better. I thank you very much for joining me on this journey. It's a journey that I hope will continue long after this lecture is over, because I, like you, am always learning. Thank you very much.